Welcome and thank you for joining us. I'm Franklin, first year medical student at Warren Alpert Medical School at Brown University, and I'll be moderating the session today. Today's session will be head and neck cases. I have a great pleasure for introducing Dr. Deng as our faculty for this case-based review. He is an assistant professor in neuroradiology at Johns Hopkins University. He authored chapters in first aid for USMLE Step 1 and core radiology. He is an editor of Radiopedia and received Radiographics Editors Recognition Award with distinction for reviewing. He has been awarded the Resident Teaching Award in Radiology twice by Harvard medical students. We are thankful for him volunteering his time today to share his knowledge and expertise with us, and also sharing some awesome cases to learn from.
Thank you, Franklin. Hi, everyone. My name is Thomas. I'm an M1 at Georgetown. I'll go over the logistics now. So this session is going to be a little bit different than traditional hot seat style. Instead, we're going to be using full EV. So please get your devices ready to answer a few questions. We're going to be monitoring the chat in order to minimize interruptions. You can save your questions to the end or message one of us, Franklin or I, with any questions you have, and we will get those sorted out. So without further ado, take it away, Dr. Deng.
Thanks so much, Thomas and Franklin. I'm going to share my screen now. All right, so thank you everyone for joining. It's great to see this robust participation. When I was taking the core, Rad Discord had just been started by Grace-Sue and others for my same year, and I found that it was very useful in my preparation for the core, listening to all these great weekend core review talks that were heavily case-based and interactive. So I wanted to be able to pay that forward and return the favor, and I thank the Rad Discord organizers for the invitation. So today we're going to do a case-based review using Poll Everywhere. Go to pollev.com/nrad. This is at the top of the screen. I'll give you just 30 seconds to be able to log in. You can choose a username because there will be a leaderboard, and your cumulative score for the competition mode will appear on that. There will be 40 seconds allotted for each question. This is on the tighter end that you may expect for answering core questions. I think on average, if you split the time evenly for the core exam, you'll have a little bit more than a minute per question. And I will also say that on average, I think the questions I have here are more difficult than the average core question related to head and neck radiology. But I do that because in my experience, the people who attend Rad Discord reviews in their free time on the weekend tend to be above average in preparedness anyway for the core. So I want you guys to excel, and so I've prepared what I think are some high yield and some more challenging questions related to head and neck radiology. So with that, I presume that most people have logged in to pollev.com/nrad. So the first question will be, what normal structure is indicated? Let's see. Between each question, there will be a leaderboard time, and if you have any questions, you can put in the chat, and the moderators will read it out during that time. And so the session, there are 40 cases. This will take probably an hour and a half to 2 hours, kind of in line with some of the other reviews. Okay, time's up. It's like 77% chose the correct answer, Vidian Canal. And second most common answer is foramen rotundum, which I expected. It is commonly confused with the Vidian canal. This is a coronal CT image showing the major skull base foramina. Here's an image from the literature showing the major foramina that go through the sphenoid bone. We have the optic canal carrying the optic nerve. We have the superior orbital fissure carrying a number of neurovascular structures. And then these two holes, the more superior and lateral one is foramen rotundum, which carries V2. And then the Vidian canal, which carries the Vidian nerve and artery as well, which is located inferior and medial to the foramen rotundum. Both of them look round on coronal images, which is why it might be confusing. But Vidian is more medial and foramen rotundum is more lateral, right? So let's take a look at our leaderboards and the names you guys have chosen. Oh, that's interesting. I may have messed up the order of my slides, so this is not stratifying by time, but I think some of the later questions will stratify by time. All right, what abnormally enhancing structure is indicated? This is another coronal image. This is an MRI post-contrast KISS or Fiesta sequence. Okay, and a plurality, 47% got the correct answer, which is oculomotor nerve. So this coronal image is going through the cavernous sinuses. Here's an image that I took from Dr. Ruttman through Twitter, showing the MRI anatomy of the cavernous sinus. What is key for knowing the answer to this question is that the third cranial nerve is located at the superior lateralmost portion of the cavernous sinuses in the coronal image, located around here. And then you may recall from anatomy class in medical school that then there's also V1 and V2 nerves. Somewhere around here is the fourth cranial nerve, but is so small that it is not visible on MRI. And then the sixth nerve is often visible, but it is located more medially adjacent to the carotid artery. So these are the cranial nerves that course through the cavernous sinus. And you should know that the most kind of round and robust one located at the superlateral quadrant is the third cranial nerve. So that prior image was actually a case of Calosa-Hunt syndrome, which is inflammation within the cavernous sinus, and it can manifest as cranial nerve palsies. In this case, the patient presented with the third cranial nerve palsy, and the MRI demonstrated that that nerve was abnormally enhancing on that post-contrast KISS sequence. Okay. All right. So soon enough, I'll have some questions that don't have the explanatory slides, so I think those will stratify the leaderboard more based on the time that it took to put in the answer. The next question is, where is the indicated abnormality? This is an axial T1 post-contrast, fat-suppressed sequence. Okay, time is up. So this image is showing actually a very small meningioma located at the tuberculum celli. And it's great that the plurality got this answer correct, 47%. The second most common answer was dorsum celli, but dorsum celli, as the name implies, is located dorsal to the sella. This general region is the sella and suprasellar region. This enhancing structure right here is a pituitary infundibulum. So the CSF around it is the suprasellar cistern. And so if we were to go one slice inferior, we would see an enhancing bony structure that would be the dorsum cella that would be located posterior to wherever the pituitary infundibulum is, whereas anterior to it is the tuberculum cellae. Now, to review the anatomy of the sellar and parasellar region here on a sagittal image from Dr. Gaillard, Frank Gaillard from Radiopedia, we have the planum sphenoidale, which is the flat part of the sphenoid body. And posterior to this is the chiasmatic groove. It's a very short kind of a transitional zone between the planum sphenoidale and the sellar structures where the optic chiasm bifurcates and kind of grooves a little bit the bone of the sphenoid. Then this little hump here at the anterior aspect of the cella is the tuberculum cellae. Here, of course, is the sella turcica, which holds the pituitary gland. So this whole area is the pituitary fossa. And posteriorly, we have the dorsum cellae, which is this projection of bone. And then this surface, of course, is the clivus. All right, the first place is tied in a four-way competition. Next question is, what abnormally thickened structure is indicated here? This is a T1 post-contrast fat-suppressed image of the orbit. Axial plane. All right, so a majority got the answer correct, which is choroid. And as I expected, the second most common answer was sclera. So let me show you the MR anatomy of the eyeball. So this is a slightly different sequence, but you can it shows the layers of the eyeball still quite well. This is taken from a radiographics paper on orbital emergencies. The sclera is a very thick and fibrous structure. Fiber structures are low signal on MRI, and so it is the thick black structure here. The layer that is interior to the sclera is the choroid. The choroid is one part of the uvea. The uvea is composed of the choroid, which reaches all the way down here, becomes the ciliary bodies, and then it becomes the iris. So the iris, ciliary bodies, and the choroid make up the uvea. The globe wall is made up of the sclera, the dark band, the uvea, the enhancing band, and then the retina, which is so thin that we can barely perceive it. On the preceding image, we know that this is thickened and abnormal choroid and not retina because it reaches all the way anterior here to the level of the ciliary bodies. If this were abnormal thickening of the retina, it would stop where the retina stops, which is about here at the structure called the ora serrata, which is kind of the serrated edge of the anterior insertion of the retina. But this was a case of uveitis. There's abnormal thickening and enhancement of the choroid. This was a disorder called Vogt-Koyanagi-Harada disease, but you don't need to know that. You just need to know that the anatomy of the globe wall is in multiple layers, and to be able to recognize that this is abnormal thickening of the choroid. Four-way tie for first. Very good. Next question is, where is the indicated abnormality? It's an axial post-contrast CT image. Okay, we have a majority getting the answer correct, which is fossa of Rosenmuller. The next most common answer was eustachian tube, followed by pharyngeal bursa. So let's take a look at the leaderboard, and let me point out some structures. So we're at the level of the nasopharynx. There are some folds in the lateral wall of the nasopharynx that are important to know. Here is the fossa of Rosenmuller. It's this deep crevice where this enhancing nodule is. It's posterior to the torus tuberous, which is the cartilaginous lip of the opening of the eustachian tube. The eustachian tube is slightly more anterior. This is the opening of the eustachian tube. It continues posteriorly and up into the temporal bone, whereas more medially and to the torus tuberous is the fossa of Rosenmuller. This is the site that is commonly the origin of nasopharyngeal carcinoma. When we report new cases of nasopharyngeal carcinoma, we may reference its involvement of the fossa of Rosenmuller. The pharyngeal bursa, also known as the pouch of Luschka, is the midline crevice that is sometimes seen. Sometimes it is filled with the Tornwald cyst. So that is the midline kind of invagination in the nasopharynx that is sometimes seen. All right, still a four-way tie for first. What structure is indicated? This is an axial MRI image. Thomas told me, we got the question, is it possible to get the context of abnormality, like what is the patient presentation? With subsequent questions where the question is about a diagnosis, I'll see if I can provide that to you. There's a mark on my screen. Why is this? The correct answer is accessory parotid gland. So we know that this is accessory parotid gland because it is along the course of the parotid duct, also known as Stenson's duct, and that wraps it up from parotid gland here and inserts. We don't see all of it here necessarily, but here it is on the left side. It inserts on the buccal surface of the vestibule here, adjacent to the first and second molars, and that's where your parotid salivary secretions go. Along the course of this duct often is some accessory parotid tissue. It should have signal characteristics that are very similar to the main parotid gland, and that's how we know it is accessory parotid gland based on its location and its signal characteristics that are similar to native salivary parenchyma. Facial lymph nodes would be more reniform, and the signal characteristics would be slightly different. Gracilis-free flap, so that would be used for facial reanimation in patients who have facial paralysis. It would be perhaps somewhere in the vicinity of this, but it would have muscle signal intensity, which on this image would be darker than the parotid gland. And then buccal fat, of course, would be fat signal intensity, like subcutaneous fat. Is there a way to delete this mark off the screen that's on the annotation? Let's see here. Here's my eraser. All right, great. Good. Next question is, what is the most likely diagnosis in this 60-year-old patient presenting with diplopia? an axial T2 weighted image with fat suppression, coronal T1 weighted image without fat suppression, coronal T1 post-contrast sequence, and then a subsequent axial T1 post-contrast sequence. Both of these are with fat suppression. Okay, this is a tough question. Very little time to simulate 4 images. So this was a cavernous venous malformation, which a third of you got correct. However, more of you chose the answer choice of capillary hemangioma. I put these two answer choices in this manner to be purposely tricky. Let me tell you the difference between capillary hemangioma and cavernous venous malformation. So traditionally, this entity was called a cavernous hemangioma. And if that were the answer choice, that would be the correct answer. More recently, people have recognized that these are malformative rather than neoplastic lesions. And so the trend has been to call these venous malformations, and they have a cavernous histology. So they're often kind of combined together called cavernous venous malformations. The entity capillary hemangioma is different from cavernous hemangioma. Capillary hemangiomas are infantile hemangiomas, and so that would not present in a 60-year-old. Infantile hemangiomas would present within the first year of life, and then they typically involute. So the correct answer here is cavernous venous malformation. What separates this from the other distractors of venous varix, schwannoma, and pseudotumor would be the enhancement pattern. We see that there's no intrinsic T1 hyperintensity. On the first post-contrast sequence, there's some puddling areas of contrast enhancement, and on the later post-contrast sequence, there's more contrast enhancement. So think about hemangiomas in the liver, how they have kind of peripheral puddly enhancement that fills in over time. It's a similar kind of phenomenon that can be seen in orbital venous malformations. So these are cavernous hemangiomas or cavernous venous malformations. And I'm not monitoring the chat, by the way, moderator. So if there's a question, please unmute and let me know in the intermission between questions. So Johnny Rads is taking the lead in first place. Okay. The next question is, what is the most likely diagnosis in this 60-year-old? Different 60-year-old, also an orbital question. This patient has vision loss in the right eye. Okay, the vast majority of you got the answer correct, which was uveal melanoma. So the key to getting this answer is recognizing that this is a T1 pre-contrast image. We see no contrast enhancement of the sinonasal mucosa here, or of the dural venous structures of the brain that are included. So we know that this is a pre-contrast image, and the CSF is dark, and so this is consistent with T1 pre-contrast image, and then recognizing that this mass within the right globe is intrinsically T1 hyperintense makes us think of things that either have blood or fat or melanin or a lot of proteinaceous gunk. In a 60-year-old with this large solid looking mass in the eye, the most likely diagnosis among these possibilities would be uveal melanoma. So the T1 hyperintensity consistent with melanin content arising from the uvea, as I mentioned in the earlier slide about the anatomy of the globe wall. This arises from the choroid specifically, but it can arise from the iris as well, but this specifically is in the posterior segment of the globe arising from the choroid, which is a subsegment of the uvea. So this is uveal melanoma, which is the most common primary malignancy of the eye in adults. It is possible to have metastases to the uvea, but it would not be intrinsically T1 hyperintense in breast cancer. And then retinal detachment has a different morphology than this. It should be looking like an uplifting of the layer in a kind of a biconvex shape to it, or a more crescentic shape to it, as opposed to this round blob that's sitting in the globe. Then retinoblastoma is incorrect because that would not occur in a 60-year-old. That is a diagnosis in infancy. So let's take a look at our leaderboard. Johnny Rad is still in first place. Okay. Next question is, what's the most likely diagnosis in this 50-year-old? This patient is presenting with proptosis. This is an axial T1 image without fat suppression. This is an axial T2 with fat suppression. This is an axial T1 post-contrast with fat suppression. This is an ADC map. Okay, very good. We have a plurality getting the answer correct, which is pleomorphic adenoma. And the next most common answers were lymphoma and dermoid cyst. So let me tell you why it's pleomorphic adenoma and not the other answers. So we have a mass here centered in the region of the lacrimal gland, so kind of superolateral orbit. That's T2 hyperintense, that has this kind of heterogeneous enhancement pattern, and very importantly, has a really high ADC value throughout the mass. Now, lymphoma would be expected to have a much lower ADC value because it's a small round blue cell tumor. It's very densely packed. It restricts diffusion much more than other tumors. A dermoid cyst would not have so much internal enhancement. Remember, it's, the contents of it are just slopped off debris, and so then the internal aspects would not have this vascularity to it. So this is more of a solid mass. And so of these choices, the most common neoplasm of the lacrimal gland is going to be pleomorphic adenoma. Now, why is it not dacryoadenitis with abscess? Again, the ADC is critical here, and abscess should show low ADC because of restricted diffusion. And then dacryops, it should just be a small cyst within the lacrimal gland. It shouldn't be this large, and it shouldn't have internal enhancement like this. All right, Johnny Raj, JH Brain in the leaderboard. The next question is, what is the most likely diagnosis in this patient with progressive blurry vision? This is a MR angiogram maximal intensity projection image. Okay, vast majority got the answer correct, which is corticocavernous fistula, or CC fistula. Now, some distractors here were central retinal artery occlusion. We would not be able to tell whether the central retinal artery is occluded. That's really more of an ophthalmologic endoscopic diagnosis. The central retinal artery is too small for the resolution of MRA or CTA for that matter. Central retinal artery is a branch off the ophthalmic artery, which sometimes we can see on MRA and CTA, but the central retinal artery is too small. The cavernous sinus thrombosis is a reasonable thought, and that might manifest as intrinsically T1 hyperintense, thrombus in the cavernous sinus. But the main finding on this image is the flow-related enhancement in the superior ophthalmic vein, which is abnormal in an MR angiogram, which is obtained with the time of flight technique. That this indicates there's some arterialization of the flow in these venous structures, namely here around the cavernous sinus, and this is connected to the superior ophthalmic vein, and this has flow-related enhancement as well, indicating there's likely some connection between the internal carotid artery, occasionally with the external carotid artery, and the venous structures that drain into the cavernous sinus, causing reflux of blood flow through the superior ophthalmic vein. And this manifests with proptosis, chemosis, diplopia, and other visual symptoms related to this venous congestion phenomena in the orbit. Okay, Johnny Rabbit, JH and brain still in the lead. Next question is, what is the most likely diagnosis in this 8-year-old with headache and diplopia? Axial T2, ADC, T1 non-contrast, and T1 post-contrast. All right, so the correct answer is pilocytic astrocytoma, and in real life, this case, the histology was predicted on the initial radiology report and proven after a month of pathology workup to be indeed a pilocytic astrocytoma. The differential would include medulloblastoma, but let me go through the imaging findings. So there is a mass centered in the cerebellum, kind of at the superior vermis and medullary velum region. It's T2 hyperintense, contrast enhancing, centrally less so. So probably necrotic in the center. But what's critical to differentiating medulloblastoma and pilocytic astrocytoma here are the ADC characteristics. This is very high, higher than brain parenchyma, several times higher than brain parenchyma, and that would be more characteristic of a pilocytic astrocytoma. If this were lower, more close to brain parenchyma in terms of the ADC, maybe slightly higher above brain parenchyma, but not this bright, medulloblastoma would probably be the best answer. Now, the other distractors in here were placed because some of you may have noticed that the patient did present with diplopia. We're looking at the eyes. There is papilledema. This is what papilledema looks like on MRI when it's very severe. You can see the protrusion of the optic papilla in the posterior globe. And you can also see restricted diffusion of this protruding disc as well, which is a common finding in papilledema. But this papilledema does not indicate tumoral involvement. Even when it's contrast enhancing, you can see that in papilledema. You can see contrast enhancement. So this should not be mistaken for retinoblastoma. Moreover, retinoblastoma is really a disease of early childhood within the first few years of life. So it's unlikely to present in an 8-year-old. And then moreover, the term trilateral retinoblastoma refers to when you have bilateral retinoblastomas plus a pineal region mass. And in this case, on the sagittal T1 weighted image, we see the pineal gland is spared and that this mass is really arising from the cerebellum. So I apologize for the pop-ups here. I'm going to close my emails and see if that resolves anything. Okay, great. So the correct answer here is pilocytic astrocytoma on identifying cerebellar mass with contrast enhancement that has very high ADC values. What is the most likely diagnosis in this 30-year-old with diabetic ketoacidosis? They're presenting with diplopia, altered mental status, fevers. Okay, very good. 97% got the right answer, which is invasive fungal rhinosinusitis. Let me go through the imaging findings here. On this T2-weighted sequence with fat suppression, we see this evil gray signal intensity in the upper nasal cavity extending to the ethmoid air cells. And there's also infiltration of the extracornal fat of the right medial orbit, as well as thickening and T2 hyperintensity of this medial rectus muscle in the right orbit. On the T1 post-contrast image, we know it's post-contrast because the cavernous sinuses are enhancing. There's hypo-enhancement of this region in the upper nasal cavity and the ethmoid mucosa, as well as hypo-enhancement of that thickened right medial rectus muscle. On the DWI, we see this large region of diffusion restriction, surrounding a central region that's less diffusion restricting. So these findings suggest a aggressive infiltrative process starting from the nasal cavity, invading into the orbit, and also causing kind of a non-vascular territory infarction in the frontal lobes. And so this would be a typical look of really bad invasive fungal rhinosinusitis. The differential is mainly the mucormycosis and aspergillosis are the main types of invasive fungal rhinosinusitis. This case specifically turned out to be mucormycosis. Very few people chose the other answer, so I won't bore you with why those are wrong. But in the clinical context of DKA or hematologic malignancy or some other type of immunosuppression, and you have a sinus process that is also involving orbit and brain, it's highly likely going to be invasive fungal sinusitis. Next question, what is the diagnosis? This is a incidental finding, so no clinical history to provide. Well, there's clinical history, but I'm withholding it. Okay, the majority got the answer correct, which is fibrous dysplasia. 37% did choose Paget's disease. However, Paget's disease is usually described as coarsening of the trabeculae and thickening of the bone, but this is marked expansion of the bone of the calvarium and skull base here, and the inside of the bone has this blotchy ground glass texture to it that is typical of craniofacial fibrous dysplasia. It's involving multiple bones throughout the skull base and calvarium here. If I told you that this patient also has a history of precocious puberty and endocrine hyperfunction, what syndrome do they have? McEwen-Albright. And this patient did have a known history of McEwen-Albright. They were getting head CT for unrelated reasons, altered mental status of some sort. And nobody provided the radiologist with the history of McEwen-Albright. They had to kind of derive it, piece it together when they saw this scan themselves. Fibrous dysplasia is the finding. And in the clinical context of endocrine hyperfunction, McCune Albright is the association that should come to mind. Johnny Rad's in the lead. Second and third place are L and JH. Next question is, what caused these defects? This is a coronal CT image. Okay, a plurality got the answer correct, which is Caldwell-Luck antrostomy. Second most common answer for functional endoscopic sinus surgery and Laporte-1 osteotomy. So what we see here are defects of the anterior maxillae that open up into the maxillary sinus, and we see there's a background of sinonasal mucosal thickening, indicating likely chronic sinusitis. And these defects in the anterior walls of the maxillary sinuses is typical for Caldwell-Luck antrostomy, which is an old-timey sinus surgery in which the surgeon goes up through the mouth above the gingiva and drills these large defects into the maxillary sinus in hopes that this will drain. The effectiveness of this was not great because the sinus mucosa still tends to beat secretions upwards through the normal sinus drainage pathway. And so these days, functional endoscopic sinus surgery is performed, meaning it's opening up of the normal drainage pathways. So you do antrostomy over here, taking down the uncinate, opening up the middle meatus and so on. This is not Laporte-1 osteotomy, which would be kind of a thinner, linear defect. Laporte-1 osteotomy is used to treat maxillary hypoplasia. You kind of make a Laporte-1 kind of horizontal fracture essentially, and pull the whole bottom of the maxilla forward. And those would be like kind of a horizontal, not as wide defect through the bone. Functional endoscopic would be, taking out stuff from the sinonasal cavity rather than making this anterior hole, which is Caldwell-Luck antrostomy. Johnny Rads, JH, and Astro, third place. I did get a question on a prior case, the pediatric cerebellar mass. Question was the pilocytic astrocytoma mainly by a diagnosis of exclusion? So I don't think it's necessarily a diagnosis of exclusion. When faced with a cerebellar mass in a pediatric patient, your main considerations are going to be pilocytic astrocytoma, medulloblastoma, ependymoma, especially ependymoma if it extends into the fourth ventricle. So there is of the most common causes, there is a limited differential, and then some of the imaging appearance can help you differentiate that based on location as well as the signal characteristics. In our case, the ADC was quite helpful. What is the most likely diagnosis in this 21-year-old man with epistaxis? The sagittal T1 post-contrast, sagittal T2, axial CT post-contrast. I believe in the arterial phase, you can see the arteries quite well. Very good. 79% got the answer correct, which was nasopharyngeal angiofibroma. This is sometimes referred to as JNA or juvenile nasopharyngeal angiofibroma, but as this case shows, it's not always presenting in juveniles. Actually, I took these cases from a 35-year-old, which is the oldest I've seen present with a nasopharyngeal angiofibroma. But even in that case, based on the imaging characteristics, we still made the preoperative suggestion that this was a nasopharyngeal angiofibroma. The imaging findings are that of a mass in the posterior nasal cavity and nasopharynx extending into the sphenopalatine foramen into the pterygopalatine fossa and widening the pterygopalatine fossa. It's avidly contrast enhancing. Even on CT, you can see the contrast enhancement and some of these higher attenuation foci that may represent internal vascularity that you can see as these rounded dark signal foci, signal voids in the mass that may be flow voids, right? So hypervascular, flow void heavy mass within the posterior nasal cavity going to sphenopalatine foramen in a young man, either an adolescent boy or a young adult man, are all kind of buzzwords for JNA, or nasopharyngeal angiofibroma. Johnny Raz, JH, and Astro still in the lead. The next question is, what is the diagnosis? This patient has rhinorrhea. And let's say they're 25. Okay, 86%, vast majority got the answer correct, which is encephalocele. So what we see is a coronal T2 weighted image where part of the frontal lobe, you see the gray matter of the frontal lobe is extending below the level of the anterior skull base. But there's a large defect here at the fovea ethmoidalis. And part of this brain matter is gliotic, as you can see with the T2 hyperintensity here. And it's kind of tapering off to a point. And there's this like cystic fluid signal intensity structure in the upper nasal cavity that's communicating with it. So this is meningocele, and this is the brain matter. So it's a meningoencephalocele, or you can just call it encephalocele or cephalocele. And this is a source of CSF leak, and patients may present with CSF rhinorrhea.
I think someone had a question regarding the Paget's versus fibrosis dysplasia case.
Yeah, so fibrous dysplasia. So the imaging findings are ground glass attenuation of bone and marked expansion of the bone. Paget's disease manifests as also thickening of bone, but coarsening of the trabeculae, kind of maintaining its usual architecture, but it looks kind of thickened and coarsened and kind of fuzzy. It's more of a kind of an Aunt Minnie. Maybe if you search up a bunch of cases of fibrous dysplasia and get used to what is the ground glass appearance versus the coarsened trabeculae appearance of Paget's disease, you'll get a better sense of differentiating the two. Beyond that imaging description, I'm not sure how much help I can provide. Okay, thanks for the question, though. This injury creates the most risk of which deformity? This is a 3D rendered view of the facial skeleton in a 12-year-old who had facial trauma. Okay, 67% got the answer correct, which is telecanthus. So the image here shows a nasoorbital ethmoid fracture. So nasoorbital ethmoid fracture involves this medial part of the midface. It is characterized by fracture lines that go through the frontal process of maxilla, the maxillary process of the frontal bone, the nasal bone extends through the piriform aperture, through the maxilla, through the floor of the orbit, up the medial wall of the orbit, and then back up. So there are a number of cardinal lines in the nasoorbital ethmoid fracture. These are classified by something called the Markowitz-Manson classification that you don't necessarily need to know, but basically there's a classification system based on how comminuted or intact this large fragment is, because that affects how surgical repair approach will be. The reason that these are repaired is for the cosmetic defect, beyond the usual consequence of orbital fractures, like stuff going on with your eye and thalamus or exophthalmos, or any compromise of the frontal sinus drainage. There's also the concern that because this is where the medial canthal tendon attaches, which is the medial part of your eyelids, that if this bone shifts because of the pull of your eyelids as you're blinking, then the medial kind of crease will pull outward. And then telecanthus is the term describing the kind of widening between your two eyes, palpebral creases. So telecanthus is the deformity that results when you have NOE fractures and increased distance between the canthus. Next case, what is the most likely diagnosis? Incidental finding on a brain MRI. Okay, so this was correct answer for 83%. This is dermal filler, so facial filler injection. Making this call is just based on the typical location of these injections, typically done along your nasolabial folds, along the marionette lines around the mouth, sometimes in the chin or the midline forehead to remove wrinkles. I have seen these been mistaken for veno-lymphatic or lymphatic malformations, as well as facial masses when sometimes patients develop a granulomatous reaction to the facial filler. It can look more inflamed, but the typical distribution is this on axial images. So knowing that and correlating that with any history of dermal filler is key to this diagnosis. Okay. Next case, what is the most likely diagnosis in this patient with conductive hearing loss? Otosclerosis is the correct answer. A synonym for this would be otospongiosis. referring to the histologic phase early on in the disease where there's a spongiotic bone replacing the normal, very dense otic capsule. So the finding is this lucency of the bone anterior to the oval window. Sometimes this area is referred to the region of the fistula antifenestrum, which is an embryonic structure that happens to correspond this, but the pathophysiology of otosclerosis has nothing to do with the fistula antifenestrum per se. It's just a fancy way for radiologists to refer to this area. But I usually say there's a focal lucency anterior to the oval window, which is a typical place for the entity of fenestral otosclerosis. What happens here is that this bone kind of overgrows the stapes foot plate, causing a fixation of the stapes foot plate, and that results in a conductive hearing loss. So that's otosclerosis. Labyrinthitis ossificans would refer to ossification of the fluid structures of the labyrinth. So there you would see bone growth where you see the fluid in the cochlea or other labyrinthine structures. And so that is not seen on this image. Cholesteatoma would be opacity in the middle ear mastoid or elsewhere in the temporal bone that's causing bone erosion. But this is just an abnormal lucency of a normal area of bone of the otic capsule. So that's not cholesteatoma.
Regarding the last question regarding the Paget's, someone followed up, wanted to know whether or not the acute or cotton wool Paget's would kind of change anything regarding that case.
Cotton wool Paget's. Yeah, I suppose that would be a reasonable part of the differential. Cotton wool Paget's. So, I've seen, calvarial Paget's disease can have a more mimicking ground glass appearance. It's typically not quite as extensive as that case of craniofacial fibrous dysplasia that I showed. Yeah, I'm not an expert on distinguishing those two, but I think if you were to get a question showing ground glass appearance of all the bones of the skull base, and it's markedly expansile, and they have any history suggestive of McCune-Albright syndrome, then you would be more confident of your answer that is fibrous dysplasia and not Paget's disease. I think another thing that would help might be the age. So that case was actually from a younger person, I think in their teens or early 20s, and that would favor fibrous dysplasia as opposed to Paget's. What syndrome is most likely in this patient? Okay, we have a T1 post-contrast MP rage image of the brain taken from Radiopedia, Dr. DeMuzio. And so this is a case at NF2. The imaging findings are this drill-based enhancing mass consistent with a meningioma. And these masses in the cerebellopontine angle cisterns extending into the internal auditory canals. You can't see the INC extension quite as much on the left side, but these is a typical appearance of bilateral vestibular schwannomas, and this is sufficient to make the presumptive diagnosis of NF2 when you have bilateral vestibular schwannomas. If you have some combination of multiple meningiomas, but not bilateral vestibular schwannomas, then you may label a person with meningiomatosis. If they have multiple like peripheral schwannomas or spinal nerve schwannomas, but not vestibular schwannomas, then they may be labeled with schwannomatosis. But if you are able to meet the diagnostic criteria for NF2, which include bilateral vestibular schwannomas or unilateral vestibular schwannomas and multiple meningiomas, then that would be NF2. So NF2, remember, that is associated with vestibular schwannomas, meningiomas, and ependymomas. Johnny Rad's JHL. Very impressive that an MS4 is on the leaderboard. What is the best diagnosis based on these images in an obtunded patient? Sagittal non-contrast CT, brain window. Sagittal non-contrast CT, bone window on the bottom. So plurality got the answer correct, which is brain abscess. So the additional clinical history in this case was the patient had a recent history of ear infection. They were treated with antibiotics and it got better. But more recently, they just felt sick and they were found by a family member down at home. And they were taken to a hospital. They're scanned with the CT scan. There are some stair-step artifacts. This is an outside hospital kind of poor quality scan. And they were found to have this large region of edema in the temporal lobe surrounding rounded, mass-like lesion that has central hypodensity. So if you see this alone, you think about necrotic mass, but in the differential would be abscess. And the things that would tip you off towards abscess in the brain, as opposed to, say, a hybrid glioma or necrotic metastasis, would be the acute presentation with obtundation. And on the bone window, what I'm trying to show you here is a huge defect in the tegment tympani or the tegment mastoideum and opacification of the air cells here. And with the history that I had withheld from you, you would put two and two together and think that there was an infection in the ear that has now spread intracranially, and this represents a brain abscess. So actually, in this case, the patient was in such extremis that they went straight to the OR for decompression, IND of this abscess without obtaining post-contrast imaging or MRI because the patient was just that sick. So I'm telling you, clinically in real life, the presumptive diagnosis was brain abscess, and that's indeed what it turned out to be.
I wanted to know a reason for why not epidural abscess.
Yeah, why not epidural abscess? So epidural abscess would not seem so round and ball-like within the brain parenchyma here. I think an epidural abscess should look more like it's lifting up a carpet here, more like a bell curve shaped kind of thing, a rounded thing like this, or potentially more crescentic. And this thing just looks like it's extending far too much into the brain parenchyma to be simply extraaxial. And the degree of parenchymal edema as well suggests that either it's extraaxial with brain invasion or it's actually intraparenchymal. And this turned out to be intraparenchymal. Okay, what kind of post-surgical change is present on this image? We have a GIF from Frank Gaillard, Radiopedia. stapes prosthesis is the correct answer. 70% of you got it right. So the underlying diagnosis here is otosclerosis. So this case of otosclerosis is much more pronounced than our prior case that was just anterior to the oval window. Not only is that area anterior to the oval window involved, but the entire otic capsule surrounding the cochlea is involved. So this is an example of both fenestral and cochlear otosclerosis. One of the treatments for otosclerosis is drilling out a hole in the stapes foot plate and putting a piston in there known as stapes prosthesis. And you connect that piston to the incus, and that provides a channel for sound waves to propagate into your labyrinthine structures. So these distractors are all different types of surgeries to the middle ear, but the one that is used to replace the stapes alone is called the stapes prosthesis. Here's a diagram showing you the other types. So on the left, we have the stapes prosthesis, which is used in the course of surgery to treat otosclerosis to replace the stapes. An incus interposition is when you have erosion of some part of the incus. So you take the rest of the incus, you kind of turn it around, you drill notches and grooves into it, and reestablish the connection between the malleus and the stapes by using this kind of turned around incus. The partial ossicular reconstruction prosthesis is used here to replace the incus and the malleus. So you have this metal stuff going from the stapes all the way to your tympanic membrane. And then the total ossicular reconstruction prosthesis, or TORP, replaces all of your ossicles. So you have this metal thing going from your tympanic membrane to your oval window. And so all three of these procedures are essentially used for cases of erosion of the ossicles due to chronic otitis media or cholesteatoma, and you're replacing parts of the ossicular chain, whereas stapes prosthesis is replacing just the stapes portion of it. Your malleus and incus are intact, and this is used to treat things that cause fixation of the stapes foot plate, most commonly otosclerosis. Next question is, what is the most common source of this infection in patients with diabetes? Telling you there's an infection here as opposed to malignancy. The typical presentation for these patients will be a diabetic older person who has ear drainage and pain. And so this image shows skull-base osteomyelitis. There's this enhancing phlegmon that's inferior to the skull base, and there is erosion of the bone of the lateral part of the clivus and the kind of inferior part of the petrous bone extending to the jugular fossa. And this is a typical appearance of skull-base osteomyelitis, of which the most common cause is malignant otitis externa. So the correct answer here is external auditory canal. Patients have a pseudomonal infection of the soft tissue structures of their external ear, especially the external auditory canal. And then because of pores in the cartilaginous portion of the EAC called the fissures of Santorini, the infection travels into the subtemporal soft tissues along fascial planes, and it continues medially and causes osteomyelitis of the petrous portion of the temporal bone as well as the clivus, and it kind of creates a phlegmon or sometimes even an abscess if untreated down here, and that's the typical pathogenesis of skull-base osteomyelitis. The other cases, other distractors here are somewhat less common. You can have coalescent mastoiditis or otomastoiditis extend medially and deep like this. You could have sphenoid sinusitis extend laterally from the sphenoid, but the most common is malignant otitis externa, manifesting as skull-base osteomyelitis. Next question is, what cochlear malformation is present? This is a patient who is a child presenting with hearing loss. Okay, the correct answer is incomplete partition type 2, which the plurality of people got. Let me show you some diagrams differentiating the cochlear malformations. It is a little bit esoteric for the level of 4, but I think it is still good to know the most common of these, which is incomplete partition type 2, and its association. So the cochlear malformations can be divided up into, whether the cochlea is formed at all. If it's not formed, then you have cochlear aplasia. If there is formation of a cochlea, but it seems confluent with the vestibule and there's not a neck in between, it's like one big space. This is called common cavity malformation. You can have a formation of a small and not complete cochlea. This is called cochlear hypoplasia. That can be a bud-like cochlea. That can be something that looks roughly like a cochlea, but it's small and the internal parts are not formed. Or it can be, formation of the basal turn and part of the middle turn, but you're missing a whole turn, and this is just bone. So these are all different types of cochlear hypoplasia. The incomplete partition are types where the cochlea external contour is normal in size and formed, but the insides, the interscalar septa or the medulus or something like that, is not formed completely. So there are different types of incomplete partition. So let me go through the main types that you should know about. The IP1, incomplete partition type 1, has been described as a figure of 8 appearance on CT, where it is also called cystic cochleovestibular malformation. You have a cochlea, you have a vestibule, there is a separation between the two, but both of these are kind of cystic appearing, meaning there's no internal architecture of the medulus and the interscalar septate. And so it just looks like one big cavity for the cochlea. Incomplete partition type 2 has sometimes been described as 1.5 turns, but it's really that the middle turn and the apical turn are not separated. There's not partitioning of the middle turn and the apex, so you don't see this notch here where the interscalar septum normally is, and so you can only count 1.5 turn, but the rest of it is cystic. The high yield association to know is that incomplete partition type 2 is associated with enlarged vestibular aqueduct, which is shown on this diagram as this funnel-shaped widening of the vestibular aqueduct. And when seen in combination, the IP2 plus enlarged vestibular aqueduct plus a slightly dilated vestibule, that is called the Mondini anomaly, or the Mondini triad, or the Mondini malformation. IP3 has a corkscrew-shaped malformation of the cochlea, but this is very uncommon and are going to be less high yield to know. So the high yield things to know are IP1 and 2, IP2 especially with its association with enlarged vestibular aqueduct. So here is a CT image showing that what enlarged vestibular aqueduct looks like. There's widening of it. Normally it should be kind of thin, like a line, but this is more a widening of it, more than a millimeter in width. And then there's kind of confluence between the middle and apical turns of the cochlea. So that's IP2.
I want a question regarding the differentiation between IP1 and CH2. They said they look similar. I think they kind of want some tips on how to differentiate.
Yeah. So the main differentiation between CH2 and IP1 is the size of the cochlea. So cochlear hypoplasia, as the name implies, that the cochlea is small. So the external contour of the cochlea is smaller than what you would expect it to be. In IP1, the external contour is roughly the size of a normal cochlea, it's just that the inside is not partitioned. Whereas in cochlear hypoplasia, you have a kind of a medium to small sized space for where the cochlea is developing. A good question. Yeah. All right, next question. What is the most likely diagnosis? The presentation doesn't really matter in this case, but let's say they presented with Horner syndrome. Okay, the correct answer is paraganglioma, and 48% of you got this correct. So what we're dealing with are masses of the jugular fossa or the jugular foramen. And the main differential for primary tumors of the jugular fossa are going to be paraganglioma, meningioma, and schwannoma. These can be somewhat differentiated based on their appearance on CT. In this case, we see a permeative erosion of the bone around the jugular foramen. And on post-contrast images, this is in the arterial phase because you can see the vertebral arteries quite well. This is very avidly contrast enhancing, which is a typical appearance of paraganglioma. Schwannomas, in comparison, should have smooth bony remodeling of the jugular foramen. Meningiomas are associated with hyperostosis of the bone. This might be seen in chondrosarcoma. This erosive appearance at the petroclival junction would be seen in chondrosarcoma, but it would not be this avidly enhancing in my opinion. And then the endolymphatic sac tumor should be located somewhat more superiorly in the retrolabyrinthine region, where you see the vestibular aqueduct normally just posterior to that, because that's where the endolymphatic sac sits. Which cranial nerve is affected by tumor? Okay, so we have 51%. Majority of you got the answer correct, which is 12th nerve. Okay, so the imaging finding to observe is this is a T1 weighted image without contrast, and there is a high signal intensity in the right half of the tongue. So this is fatty infiltration of the right hemitongue. And so you got to know which cranial nerve supplies muscle motor innervation to the tongue, and that would be cranial nerve 12 hypoglossal. So a common mistake is to think the 9th nerve, the glossopharyngeal nerve, has anything to do with that. But the glossopharyngeal nerve, the glossal part, is really the taste to the posterior tongue, the sensation to the back of the throat, and it has some motor component, but that is only the silopharyngeus muscle, which elevates the palate. So the intrinsic muscles of the tongue are controlled by cranial nerve 12 hypoglossal. So to give you an oversimplified view, this is with a few exceptions. Cranial nerve 5 controls the muscles of mastication. Cranial nerve 7 controls the muscles of facial expression. Glossopharyngeal controls silopharyngeus muscle, and then it has the other sensory functions. The vagus nerve controls most of your laryngeal, pharyngeal, and palatal muscles. There are some exceptions. The accessory nerve controls your sternocleidomastoid and trapezius muscle, and the hypoglossal nerve controls most of your tongue muscles. If asked which side might be involved on that prior question, so fatty atrophy means the right side is involved. So the ipsilateral cranial nerve 12 is involved in this tongue palsy. But you might read in your clinical notes that if you ask the patient to stick their tongue out, the tongue will deviate to the right. That's because the strong side of the tongue will still work, and it kind of curves you this way. All right, next question. What structure is most likely indicated in this patient with trigeminal neuralgia? This is a sagittal, heavily T2 weighted image. So KISS or Fiesta sequence. Okay, the correct answer is superior cerebellar artery, and the majority of you got this correct. So on the sagittal image, this structure that courses horizontally in the cerebellopontine angle cistern is the cisternal segment of the trigeminal nerve, and that enters the porus trigeminus and then kind of fans out in the Meckel's cave. Trigeminal neuralgia is commonly caused by neurovascular conflict, meaning a vessel is abutting or impinging or deviating the trigeminal nerve, typically somewhat proximally in the cisternal segment. The most common neurovascular conflict implicated is the superior cerebellar artery. The SCA runs kind of over here. Sometimes it takes a loop inferiorly and will abut the trigeminal nerve. Occasionally, other arteries will be implicated. ICA rises from the proximal basilar artery and may loop upward and abut the trigeminal nerve. Pica and vertebral are all farther away and only rarely, if very tortuous and elongated, will affect the trigeminal nerve. So the most likely vessel implicated in trigeminal neuralgia is the SCA, followed by the ICA, followed by basilar artery, vertebral artery, and sometimes the petrosal vein. The petrosal vein is also known as Dandy's vein and runs in a vertical fashion in the CP angle, as opposed to kind of back, looping in the anterior-posterior dimension. Other neurovascular complex syndromes that are good to know about but less common are hemifacial spasm, which is due to impingement of cranial nerve 7. And this most commonly implicates ICA, followed by pica and vertebral artery, and then glossopharyngeal neuralgia, which is even more rare, which is impingement of cranial nerve 9 in the cisternal segment, usually by pica, followed by ICA. So you can see as you descend in the brainstem from 5, 7 to 9, it kind of follows that you go inferiorly in your vascular anatomy in terms of which vessels implicate superior cerebellar artery, followed by ICA, followed by pica inferiorly. Next question is, what additional injury is evident in this patient with C1 fracture? This is an axial T2 weighted image. Great, so vertebral artery occlusion is the correct answer. So what we see here is that there's all this stuff going on the left C1 lateral mass, and this low signal intensity structure represents a fracture fragment that has been displaced posteriorly and laterally. And this is an important area because this is where the V3 segment of the vertebral artery curves before it enters the dura and penetrates the dura over here. So on the contralateral side, you can see a normal flow void to the vertebral artery while it's still in the transverse foramen and it's curving around here. Whereas here, we've lost the flow void, it's hyper intense, and vertebral artery occlusion is the diagnosis here. This may be due to dissection or other type of injury to the vertebral artery, and that has halted the flow. So you see a loss of the flow void here. All these other distractors are things you would look for on a trauma C-spine scan, but not present on this image. So carotid artery dissection. So here are the flow voids of the carotid arteries, and they are still intact. Okay, Johnny Rads, Astro, JHL, and then Bradley MS4. What is the most likely diagnosis of the left-sided lesion? This patient has nasal congestion. Okay, the correct answer is antrocoinal polyp. You guys have this. Vast majority of you got this correct. The imaging finding is this T2 hyperintense structure filling the maxillary sinus, extending out the maxillary ostium, the osteomedial unit, filling the left nasal cavity, going posteriorly through the choana into the nasopharynx. And on the coronal T1 post-contrast image, we see no internal enhancement. There is some peripheral enhancement related to the enhancement of the mucosa around this lesion, but the insides are not really contrast enhancing. And so this is kind of like a mucus retention cyst that has gone huge, and it's been kind of beaten out and elongated and pushing into the nasal cavity, and the nasal cavity mucosa continues to beat it backwards through the choana into the nasopharynx. So this is the typical trajectory of antrochoanal polyp, antro meaning maxillary sinus, choana meaning the posterior opening of the nasal cavity. So it's the antrochoanal polyp. Whereas a Schneiderian papilloma would have more internal enhancement. A branch of which cranial nerve is involved with perineural tumor spread here? This is an axial T1 post-contrast image with fat suppression. I'll tell you, this patient had a cutaneous squamous cell carcinoma of the face. Okay, the correct answer is B3, and a plurality got it correct. B3 is the right answer here. Specifically, this is the auriculotemporal nerve, which is a branch of V3. So it's important to recognize that the axial level that we are at is kind of around the mandibular fat pad, just inferior to the skull base. And this is where V3 branches go. V3 branches include the auriculotemporal nerve, and other branches include the inferior alveolar nerve, the lingual nerve, and so on. But they branch kind of around this area. The one that goes laterally is the auriculotemporal branch, and this goes all the way to the parotid gland, where it may meet branches of cranial nerve 7. Cranial nerve 7 doesn't dive this deep into the face. Cranial nerve 7 emerges from the stylomastoid foramen somewhere in this region, and then goes through the parotid laterally and spreads out over the lateral side of the face, innervating your muscles of facial expression, it would not course deep towards kind of these muscles, which are the muscles of mastication that are innervated by cranial nerve V3. V2 would be at a more superior level, such as in the pterygopalatine fossa and orbital nerve canal going anteriorly. So that would not be the correct axial level to demonstrate V2. Sorry, yeah, V2. Okay, next question is, a branch of which cranial nerve is involved with inflammation here? This patient had a rash on his face. Okay, great. Majority you got this correct, which is V1. So this patient had herpes zoster ophthalmicus. They had a V1 distribution, vesicular rash, and facial swelling. And sometimes people have like hypoesthesia of this region. Sometimes people have orbital or ocular symptoms, which results in getting imaging of the orbits to delineate the extent of intraorbital involvement. In this case, there was a thickening and enhancement of the V1 nerve. This is either the frontal nerve or the more proximal trunk of that, which is the ophthalmic nerve, or V1. This courses along the superior orbit, right along the orbital roof, superior to the superior rectus and levator palpebrae superioris muscle complex. So this is V1. All right, Johnny Rad's still in the lead. Bradley MS4 pulling up into 4th place. Nice. What technical change would reduce the indicated artifacts in this image? So I'm mixing in some physics with this head and neck review. You have to recognize what sequence is this, what are the artifacts that are being indicated, and what is the way to reduce these artifacts? This patient presented with hearing loss. Okay. This patient had a cholesteatoma, and that is typically depicted on MR imaging by an area of restricted diffusion within the temporal bone, typically the middle ear or mastoid. It's very difficult to see sometimes on conventional DWI because conventional DWI is obtained with an echoplanar imaging technique, which is optimized for the brain, but at the skull base, because of the rapid shifts in the susceptibility, there is creation of eddy currents, which causes the geometric distortions and piling up of signal and signal loss in other places. And so the main way to reduce these distortions and signal pileup artifacts on DWI is alternative ways to traverse case space, the most common of which can be grouped under the umbrella of non-EPI based DWI techniques. An example of this would be HASTE, which is a turbo spin echo based version of DWI. You have a HASTE DWI. Other people use BLADE or propeller, which traverses case space in a radial fashion, and rather than like a zigzagging EPI manner. And there are also manufacturers that make a readout segmented EPI, so you kind of divide each plane into multiple segments rather than traversing all of it in one echo train. So, so those are the various methods. Most common way to do cholesteatoma imaging is with some non-EPI based version of DWI. The other distractors here make susceptibility and eddy current artifacts worse. So moving to higher field strength makes it worse. Decreasing the receiver bandwidth would make it worse. Disabling fat suppression would increase the signal associated with the bone marrow here. So you have like more signal to distort and pile up on each other. So that would make it worse. And disabling parallel imaging would make EPI, DWI even slower, and that would make the distortions even worse as well. All right, what is the most likely diagnosis? No clinical history provided here. This could even be an incidental diagnosis. Okay, 78% of you got the correct answer, cholesterogranuloma. What we're dealing with is a lesion at the petrous apex, and we know it's not just normal bone marrow because this is expansile. On this T1 pre-contrast image, we see there's no contrast enhancement of any like normal structures, including the nasal mucosa. But this is T1 hyperintense, and we know it's not fatty bone marrow because it's large and expansile. So that makes us think of cholesterogranuloma. A T1 hyperintense petrous apex lesion that is expansile is going to be a cholesterogranuloma. The T2 coronal image here kind of corroborates that. There are some areas of high signal intensity, some areas of low signal intensity, and that just reflects the heterogeneous composition of cholesterogranuloma, which is like a bloody cyst. The other options are not correct simply because of the signal characteristics here. Chondrosarcomas would occur at this site, but would not be intrinsically T1 hyperintense. Nor would cholesteatomas, and then fatty marrow would be T1 hyperintense, but not expansile like this. Okay, Johnny Rad's Astro Bradley MS4, and then inverted papilloma. Very nice. Which anatomic axis corresponds to the frequency encoding direction on this image? So this problem sometimes arises in head and neck imaging where you have artifact that projects over some lesion of interest, and one way to troubleshoot that artifact is to change your phase encoding and frequency encoding direction. Usually the setting is phase encoding direction, and frequency encoding is just whatever is perpendicular to that. So I asked my question a little bit weirder, unconventional way, asking which one is the frequency encoding direction. So the phase encoding direction would be AP because this pulsation artifact is being projected into the AP direction. And so perpendicular to that on this image would be left, right. So that would be frequency encoding. That is the correct answer that most of you got. You guys are ready. You guys are ready for the core. Next question, what is the most likely diagnosis of the indicated finding here? This is incidental on an IAC protocol MRI performed for hearing loss. And you just notice a thing indicated there. This is your KISS or Fiesta sequence, heavily T2 weighted, and then this is a post-contrast T1 sequence at the same level. Okay, just pause for a second. On the last question, somebody asked why not superior, inferior. I guess that's that would be perpendicular to the image, and I guess you could make the argument that is also frequency encoded. The slice selection is frequency encoded, but I guess I was asking on this image, which direction is frequency encoding? And so the answer is on this axial image you have left, right, would be the frequency encoded direction. Okay. So this lesion in the prepontine cistern projecting from the clivus is ecordosis physolifera. This is a benign notochordal remnant. It has this typical appearance where you have a little nubbin that is T2 hyperintense and non-contrast enhancing that projects into the prepontine cistern. Sometimes it's bigger than this, but this is a typical size for this lesion. It's associated sometimes with a projection of bone at the stalk of this lesion, which is difficult to see on MRI, but sometimes there's also a corresponding divot into the clivus as well. And so you don't have this normal marrow enhancement in this little divot associated with this abnormality. So, in the differential would be chordoma. Chordoma would be contrast enhancing, but it is typically offered in the differential when you're calling a ecordosis physolifera, because especially if larger, because they are both neurocornal remnants. Clival osteoma is not exactly the right answer because of the signal characteristics. Osteoma should be more like bone and low signal intensity on T2. Epidermoid cyst would be T2 hyperintense, but it would not have this stalk like connection to the clivus. Okay, Astro taking the lead. What is the most likely diagnosis in this 40-year-old? They're presenting with a neck mass. Okay, great. 63% got oropharyngeal squamous cell carcinoma. So what we have is, you may have noticed a cystic abnormality in the left neck. But in a 40-year-old, even if you see just a cystic abnormality, the first thing on your differential should be squamous cell carcinoma. People who are 40 and above should lead with squamous cell carcinoma. It's cystic nodal metastasis of squamous cell carcinoma until proven otherwise. In this case, there are even more imaging findings that are highly suspicious for squamous cell carcinoma. There's this enhancing solid mass next to this cystic lesion. In addition, you want to look for the primary lesion. There's this thickened soft tissue enhancement in the left oropharynx at the left, palatine tonsil, and this proved to be oropharyngeal squamous cell carcinoma, P16 positive, i.e. HPV related, with cystic nodal metastases and also solid nodal metastases. So all these imaging findings, the age, are most compatible with oropharyngeal squamous cell carcinoma. What is the most likely diagnosis in this 40-year-old? They presented with a neck mass. As in they felt something in their neck. Okay, we notice that this is a post-contrast CT. It's a very good arterial, well, I think this is a routine post-contrast CT, not a CTA per se, but nevertheless, we can notice that there's good contrast enhancement of the arteries as well as the veins here, but that this mass is very avidly enhancing, almost as hyperattenuating as the arteries themselves. And this is located at the bifurcation of the carotid artery into the external and internal. So common carotid, internal and external carotid artery. And so this is the location of the carotid body. And when you have enlargement of the carotid body with an enhancing mass, that is a paraganglioma. It's also known as carotid body tumor, previously known as chemodectoma. So paraganglioma is the correct answer, and 95% of you got this right. So I'm not going to belabor the answer here. On angiography, you can notice, hypervascularity of this and splaying of the carotids, what is known as the lyre sign, because these are, it takes the shape of a lyre on the sagittal or the lateral projection. All right, Astro in the lead, pulling ahead. What technical change would improve the quality of this image for temporal bone evaluation? So this is a face CT, and say I wanted to do either a redo or a reconstruction of the same acquisition in order to better look at things in the temporal bone. Okay, this is a decreased display field of view. Okay, so let me pause here for a second and see how many additional cases I have left. It's not that many. 1, 2, 3, 4. 4 cases left. All right. So the answer was decreased display field of view. That is the correct answer because that allows you to reconstruct your images such that the pixels are smaller within your matrix. So say you have like a 256 by, or say you have a 512 by 512 matrix, and this is being represented by this whole image here. Well, let's say you can focus on this region of interest and reconstruct it with a 512 by 512 image, then you can see stuff that much more clearly if you can do this dedicated small field of view reconstruction. All the other answers would reduce your, make a resolution worse than it is. Okay, what is the most likely diagnosis? This image, patient has voice changes. Let's say they're a 45-year-old presenting with dysphonia, and so they got a CT neck. Okay, chondrosarcoma is the correct answer here. We have this low density mass, but some areas of higher density that may represent chondroid matrix, so rings and arcs calcifications. The main thing to notice is that this is centered in the thyroid cartilage. It's splaying apart the cortex of the thyroid cartilage. It's kind of like the bone version of the claw sign. So the mass is arising from the thyroid cartilage, and it has chondroid matrix. So this is a chondrosarcoma, which is going to be the most common submucosal malignancy of the larynx. We know it's submucosal because it's this is not related to the mucosa of the larynx. It's medially deviating this paraglottic fat, and so that's most compatible with the submucosal location of this, and the imaging findings compatible with chondrosarcoma. Okay. All right, astroinverted papilloma and L in the lead. Wow. What is the most likely diagnosis in this 20-year-old presenting with neck mass? Neck mass, neck swelling. Hodgkin's lymphoma was the correct answer here. So I would raise the suspicion of lymphoma based on the fact that there are multiple and large lymph nodes in the bilateral neck, left greater than right. There's also a mediastinal mass here that you can partly catch. And so this is a classic distribution, neck or mediastinal involvement in a 20-year-old. This is the typical age range for Hodgkin's lymphoma as a peak in incidence in young adults. If you see like a solitary nodal metastasis in the supraclavicular region, it might be a Virchow node arising from gastric adenocarcinoma, but this would be a older demographic. Anaplastic thyroid carcinoma, also older demographic. You see more like necrotic stuff, and you'd see a thyroid mass as well. Rhabdomyosarcoma, not typically this multinodal kind of appearance. So Hodgkin lymphoma is the best answer. You guys got that correct. Let's see, there's a question here. Does Hodgkin's lymphoma typically favor left side? I don't know that laterality to be a thing, but maybe somebody else there does. I don't know. All right, I think this may be the last case. What is the origin of the indicated structure? We have a coronal CT angiogram and a transverse ultrasound duplex or color Doppler image at right neck level 4. Occasionally on the core, you'll see questions. There's like random things that require some kind of problem solving thinking. And their intention is that to test things of practical importance, they might not always be some catchy disease entity. But in this case, it was a real world, diagnostic dilemma when the radiologist saw this on a thyroid ultrasound of this kind of Pepsi appearance on color Doppler, suggestive of a pseudoaneurysm. But then the question was, where did it arise from? On the transverse ultrasound image, like you can see that this is the common carotid artery, and then this is internal jugular vein that's being kind of compressed by this more laterally located abnormality. And then on the CTA, this patient had a right arm contrast injection through the right upper extremity. So all the really dense contrast is still in this subclavian vein here, which turns into the brachiocephalic vein here. The internal jugular vein is coursing along here, and it's not opacified with contrast because this is a CT angiogram, and you have to know that most of the contrast has reached the arteries but not drained into the veins yet. And this is from the tail end of the contrast injection, and this is so dense because it's refluxed up from the subclavian vein. And so that's the kind of thinking you have to go through to determine, okay, what is this structure? Why is it so dense? That's because it's reflux contrast, not venous phase contrast per se. This is a CT arteriogram, and it's much more dense than the arteries, so it can't be coming from the arteries. It's much more dense than this internal jugular vein, so it can't be coming from that. This is refluxed up from the right arm contrast injection. So unfortunately, only 9% got that answer correct, but hopefully you guys have enjoyed this board review, and hopefully you learned something. Wow, I have another question. One last question. Might be. What is the next step in management for this patient with acute neck pain? Okay, that's good. This is a better one to end on, I think, because I think more people will get this than 9%. Bonus, yeah, for people who stayed through the credits, stayed through my. Thanks for joining us, comments. So for the prior case, the subclavian pathology was, I don't know, idiopathic. It could be iatrogenic. Somebody had a central line and you poke the vein, and the vein like ballooned out, and you have a venous aneurysm or venous varix, whatever you want to call it. So you can either call it a subclavian venous aneurysm or a venous varix. Okay, and the answer here is naproxen. Okay, so the finding here is in the prevertebral space. Okay, the CT is key here, right below the C1 arch. So we're at the level of the den, so it's right below the C1 anterior arch. There's this amorphous calcification on this MRI. This patient had, this fluid signal intensity, this edema, the prevertebral musculature. There's this kind of amorphous contrast enhancement, but no rim enhancing fluid collection. So it's unlikely to be a retropharyngeal abscess. And this amorphous calcification in combination with acute neck pain is really classic for calcific tendinitis of the longus colli muscle, which should appear as this amorphous calcification of the tendon. And so this is treated with NSAIDs, not antibiotics, not incision drainage, not biopsy. So that is that. All right, so check out the chat, please. And there's a link to a Google form for how RAD Discord can improve. And I think that's it. Yeah. Oh, actually, you know what? Here's one more thing. If you guys are still on my full EV thing, would love it if you can give me a numerical rating. This is anonymous, by the way. So if you're still logged in, you can give me a numerical rating, and this just helps me in developing my CV and educator portfolio. And then you guys can stick around for one more minute. There's also a free response thing about my session in particular, but this would be supplemental to the Google Forms that's in the meeting chat that's more applicable to RAD Discord in general. Okay, I'll close this one and move on to the next one, which is any free content, free text comments whatsoever. What did you like? What did you learn? What worked well? What would make my board review even better? And by the way, this will be recorded for on-demand review by RAD Discord members later on. Thank you guys so much for participating.
Thank you again for that awesome case review and for all the residents that joined today. Hope we all found that useful. And again, please fill out the feedback survey and let us know what you think. And good luck studying in